Here's a voiceover on some more common genetic conditions that you may see clinically in children that you work with. We're going to be going over 3 genetic conditions, not including Down syndrome in this one. I left Down syndrome in another separate PowerPoint because there's a little bit more information on Downs, and it is probably the most common genetic condition. But what I'd like you to get out of this particular lecture is understand the etiology and symptoms associated with common genetic diagnoses, and discuss those initial implications on occupational performance of those people who are diagnosed with these conditions. The 3 genetic conditions that we're going to be talking specifically about is Fragile X syndrome, Angelman syndrome, and Prader-Willi syndrome. And again, these are 3 genetic conditions. When I say genetic conditions, I'm referring to information that's passed down from the genes. It's passed down or inherited from your family members, like your great-grandparents to your grandparents to your parents, and parents to their children. If this inherited or genetic information is changed so that it becomes faulty, also known as a mutation, it could cause a genetic condition, and that genetic condition could affect growth, overall development, or even somebody's health. Many of the health or developmental conditions that are seen at birth are typically due to a fault in the genetic information, or a combination of inherited genetic information along with environmental causes, like maybe poor diet or chemical exposure, possibly to lead paint or some other chemicals, and even certain lifestyles. Other genetic conditions may not be noticed until later on in childhood, may not be identified or noticed until adolescence or even adulthood in some cases. Looking specifically at Fragile X syndrome, Fragile X is a maternal chromosomal abnormality. Its prevalence in males is 1 in 3,600 births, and in females is 1 in 4,000 to 6,000 births. Impairment in Fragile X is highly variable. There's some sources out there that males are more affected than females. Some reasoning behind that is when we look at the sex chromosomes for males, they have an X chromosome and a Y chromosome. Well, Fragile X occurs on the X chromosome, so boys only have one X, so they may be more affected by the syndrome. Girls, on the other hand, have 2 X's, so their sex chromosomes are XX, as opposed to males that are XY. So they have one X that's affected, where the other one wouldn't be affected. And so in order for females to have symptoms of Fragile X, both of their X's would actually have to be have some sort of mutation in it. I've worked quite a bit with individuals with Fragile X, and I agree that impairment is highly variable. I've worked with 2 brothers that both had Fragile X. One was really high functioning, and the other one was really low functioning. Both from the same family, both with the same genetic makeup, and they weren't diagnosed. The older one wasn't diagnosed with Fragile X until quite a bit later. They knew something was wrong. He was having a lot of learning difficulties, but he wasn't actually diagnosed until school age. They underwent some genetic testing when they found out that their school-age child had a genetic disorder. And the mom happened to be pregnant at the time with her second child, and so they were able to run some tests while she was pregnant, and they found out that their second child was also going to be born with Fragile X. So from there, they decided not to have any more children because they had their hands full with 2 children that had special needs, and that was their choice as a family to make. But again, males with Fragile X, some sources say that they do have lower functioning, again because it affects the X on the XY chromosome. Some physical characteristics that you may see In males, you're going to see longer faces, more prominent ears that stick out a little bit farther. Their ears are often wider, and again, they stick out, so they're projecting away from the head, and they may have enlarged testicles. Females, on the other hand, may have some similar characteristics, but typically they're of a lesser degree, and it could impact their menstrual cycle in some of the female characters or carriers. I also worked with a girl with Fragile X, and her mom has Fragile X also. And her mom was able to hold down a full-time job, and she works currently and still works as a caretaker, as a CNA in a skilled nursing facility. So it's quite interesting to see how you can see her functioning in society. The mom has some issues with some problem solving and some abstract kinds of thinking. And the daughter, whom I saw for quite a few years, had a lot of problems with low muscle tone. She had a longer face. She had more prominent ears also, and she had a lot of drooling. She had a lot of self-stim behaviors also. They may have connective tissue issues as well. They may have loose connective tissue. So the little girl that I saw was, quote, double jointed, meaning she had hypermobility in her joints, which could also be, some low tone issues as well, low muscle tone. You may see some ear infections. Males are more likely to have ear infections due to a poorly structured eustachian tube. Their circulatory system, they may have mitral valve prolapse, having to deal with their heart. Some of them have cutis verticus gyrata, which are unusual folds on the scalp as a result of some thickening skin. And some people that are more common is flat feet among individuals with Fragile X as well. So none of the children that I saw with Fragile X had the cutis verticus gyrata, or at least that I noticed. But they all had flat feet, interestingly enough. You'll see quite a few behavioral characteristics of individuals with Fragile X. You'll see distractible and impulsive types of behaviors. Some are on ADHD medication and are treated for ADHD as well. You may see hand flapping and chewing on items, which is kind of connected to sensory processing problems and how they deal with anxiety. The girl that I saw would do a lot of hand flapping every time she would get excited. And she would mouth her hands too and bite on her knuckles to the point where her knuckles would get red and she would have bite marks on her hands. We tried giving her some different jewelry that was made to chew on, because she was starting to chew on some of her shirts as well as, her hands, and chewing on your hands is not very clean and contributes to illness because hands are always germy. So I worked a lot on her on hygiene. And she also had speech therapy, who did some of the stretching inside the mouth to help with drooling. But anyway, there's a lot of sensory processing problems and a lot of anxiety as well. One of the boys that I worked with had a lot of anxiety. He was actually being treated for some of his anxiety. And anytime I pulled out a standardized assessment for him that was timed, he would have a great deal of anxiety. He would get up, he would push his chair down, he would start pacing, and he would have a really difficult time getting to the table. Sensory processing problems are manifested as tactile defensiveness, so they may have some defensiveness associated with touch. The girl I worked with absolutely hated her head touched. And of course, she had long hair, and she refused to let her mom brush her hair. And her mom, growing up with the same Fragile X disorder, was like, fine, I'm not going to cut your hair and I'm not going to brush your hair. And it just became this horrible, horrible rat's nest. So we worked extensively on decreasing her tactile defensiveness to her scalp, and then we got to the point where she was able to brush her own hair. So that was a good thing, but it took a couple years, honestly. I mean, that's how intense it was. Hypervigilance. Kids will be worried about changes in their routine or upcoming stressful events. So that older boy that I saw with Fragile X, he'd be like, we're not going to have a test today, are we? Or, he would just constantly be worried about that silly standardized test. You may see rigidity with intense emotions. So they may stiffen up when they're angry or upset. You may also, like the girl that I saw with Fragile X, when she'd get really excited, she would do hand flapping, and she would make her jaw really rigid as well. And so just any type of intense emotions, whether it's happy or sad. You'll see tantrums as a result of anxiety and feelings of being overwhelmed. And new situations may cause behaviors, and they may want to remove themselves from the situation. So that older boy that would get up from the table when I would try and test him with an assessment tool, he would just get up and try and leave. Imagine how that works in the school system in a classroom when he's trying to learn a math problem, and he has a really hard time, and he's getting up in the middle of class and causing a scene with his classmates. So that caused quite a bit of problems as well. Cognitive characteristics. Delays are noted. Up to 80% of males are diagnosed with some sort of cognitive delay. And so here's where you see that intellectual disability come into play also. They tend to move at a slower pace and have a lower end result than your typically developing child. So they may not draw a triangle as well right away. They may not be able to write their name as efficiently as a typically developed child. Again, they're affected by ADHD as well. There's also higher incidences of seizures in individuals with Fragile X. You're going to see speech delay with individuals with Fragile X. And you're going to see a lot of anxiety. And again, this impacts test taking. It impacts standardized assessments. It affects their ability to learn in a classroom. Some social characteristics. You're going to see some perseverative speech. And this is a symptom of anxiety. And when I say perseverative speech, I mean that they repeat the same thing and they kind of perseverate on the same issue or on the same thing. So the girl I saw loved Hannah Montana. She loved Hannah Montana to the point where she would get a Hannah Montana reward at the end of our treatment session, whether it be a sticker or we'd get to listen to some of her music. And we could dance to some of her music if we worked on some of the other things that we needed to work on. But throughout the entire treatment session, she'd be repeating, Hannah Montana, Hannah Montana, and she kind of slurred her speech, so it was quite funny, really. And then to hear her try to sing different songs to Hannah Montana was very rewarding and very very funny also. Sometimes they have difficulty with eye contact and they have difficulty sustaining a conversation. And think about how that is with your peers if you have trouble making that eye contact. You have trouble sustaining a conversation. So the older boy with Fragile X that I worked with, he would say, he was scripted to say, "Hi, how are you?" But then he would often look down at the floor and pace back and forth and turn around and just walk away and not wait for a response from the other person. Or he'd wait for a response, but then when they would ask him how he's doing, he would just not say anything and walk away. So again, he's having a lot of anxiety, so a lot of social anxiety, and his thing was to flee and to leave anything that made him feel uncomfortable. They have difficulty with socially accepted behaviors. So again, the poor eye contact. In our society, typically, eye contact is an important socially acceptable behavior. And so Some of these children aren't going to be doing that as readily. Hand flapping, kids would point and laugh at some of my clients when they would get excited and when they would hand flap. And again, walking away from conversations and demonstrating poor social skills is also an issue. These kids sometimes act shy because they're very anxious. Some kids will even express some depression, and depression are more likely to occur in females. However, the older boy that I saw with Fragile X, I would say was more depressed than any of the other children that I worked with. And girls with a few mutation have that Fragile X gene, again, because girls are XX for their sex chromosomes, and so they have to have the full mutation on both of their X's to get that Fragile X gene. Looking at Angelman syndrome, Angelman's is less common, and it's estimated that 1 in 15,000 to 1 in 20,000 births result in Angelman syndrome. It mostly affects Caucasians in North America, which I think is interesting, and it occurs because of a deletion on the maternal 15th chromosome. So they've identified it and they've narrowed it down to exactly the 15th chromosome, and that's been deleted, so that's not passed forward. You'll see normal prenatal and birth history with the normal head circumference, and there's going to be an absence of major birth defects. However, by 6 to 12 months of age, you're going to start seeing those developmental delays. So by 12 months, we know a child should be standing and taking the first step, so you're going to see that as significantly delayed. Also 12 months, they're starting to say some simple words, and so they won't be reaching that either. Even though there's a delay, there's still a forward progression of development. So they may not start taking steps until 15 months. So there's no loss of skills. It's just they're slower at attaining those skills. They have normal metabolic, hematologic, and chemical lab profiles. So their blood work is all typical. And they have structurally a normal brain using the MRI or CT scans. They may have some mild cortical atrophy, so some atrophy of the brain and some dysmyelination, so that myelin sheath may be less in some of the brain structures, but typically it's structurally normal. Genetic classes of Angelman's. You could have maternally inherited, which is that absence of chromosome 15. You can have a paternal uniparental disomy, which is only 2 to 3% of the cases, so it's really, really rare and unlikely. And this is when a child inherits both copies of chromosome 15 from the father, and no copy is inherited from the mother. So they're missing the active gene from the mother still. And the paternal chromosomes only have the inactive gene, and they're getting 2 of those paternal chromosomes, okay? So I don't worry about the UBE3A gene. All I want you to know for the paternal uniparental disomy is it's 2 to 3% of the cases, so it's very rare. And the child inherits both copies of chromosome 15 from the father, and because they're from the father, they're inactive. So it's the absence of chromosome 15 because they're not active. So in paternal uniparental disomy, they're there, but they're not active, so they're not expressed, which results in Angelman syndrome. There's also imprinting defects, which occur for 3 to 5% of the cases, so again, pretty rare. And this is where the child inherits chromosome 15 from the mother and the father, but the copy from the mother functions the same way as the paternal. So the paternal, again, typically chromosome 15 on the paternal side is inactive. And so in imprinting defects, the mother's chromosome 15 is inactive. And then the paternal is inactive. So then, again, both are inactive, which is that absence of that chromosome 15. So again, the difference is the paternal uniparental disomy, they're getting both cases from the father, and chromosome 15 is not active from the father, where the imprinting defects is they're getting one from the mother and one from the father, and the one from the mother that should be active is not active. Some of the clinical features, and so consistently, somebody with Angelman syndrome, you're going to see developmental delay. You're going to see speech impairment. You're going to see ataxia or tremulous movements of the limbs, okay, so the shakiness. You're going to see behavioral uniqueness. There may be any combination of frequent laughter, smiling, a happy demeanor, easily excitable personality, and that's why they get the Angelman syndrome, because they're little angels. They're happy. You also may see some hand flapping movements, and you may see some hypermotoric behavior. So hypermotoric behavior is kind of frequent movements or rapid movements. So maybe with the hand flapping, that would be a hypermotoric behavior. You'll also see some significantly shorter attention spans, which is going to affect their learning. Some frequent clinical features that happen to more than 80%, you'll notice some microcephaly by age 2. Microcephaly is a small head size. So again, you'll see that by age 2. You typically will see seizures, and usually their onset is when the child is under 3 years of age. So birth to 3, you may see some seizures, and you're going to see an abnormal EEG as well. Some of the other associated behaviors, which occur in about 20 to 80% of those with Angelman syndrome, is strabismus. Strabismus is when you're looking at the same point at the same time, but your eyes are looking somewhere else. So if I'm looking at my clock on the wall, maybe one eye is looking on the clock and maybe one eye is looking somewhere else. Okay, so it's kind of like that lazy eye that we've probably seen. Hypopigmented skin and eyes. So you may see some, due to their low production of certain hormones, you may see lighter skin or lighter colored eyes. You may see tongue thrusting, so them sticking their tongue out repetitively, which would result in maybe some suck-swallow disorders as a baby. You may see some hyperactive tendon reflexes. So when you go to the doctor and they tap your knee and you kick, these kids may kick really, really far because the reflexes are hyper. You're going to see feeding problems during infancy. They may walk with an uplifted, flexed arm, that high guard position when walking. They have a more prominent mandible. They have sleep disturbances. They may have increased sensitivity to heat. They may have a wider mouth with wider spaced teeth. You may see frequent drooling, and again with the tongue thrusting, you may see that protruding tongue. Something that I think is really interesting is individuals with Angelman syndrome have an attraction or fascination with water. So they may walk by a water fountain and just be drawn to the water. You may have excessive chewing or mouthing behaviors, and sometimes the back of their head is flat. Moving on to Prader-Willi. Prader-Willi looks at the genes on chromosome 15 are missing or unexpressed on the paternal chromosome. Okay, so on Angelman's, it's on the maternal. On Prader-Willi, it's on the paternal. So Angelman's is on the maternal, Prader-Willi's on the paternal. I don't know if I said that wrong the first time. The genetic classes, 70% are paternally inherited. Okay, so it's coming right from the father. 25% is the maternal, and then the UPD is the uniparental disomy. So again, the maternal is supposed to be activated. But for this case, it isn't going to do what it's supposed to do. And there's no paternal chromosome for it to follow up on. 2 to 5% again are on imprinting errors as well. So the paternal contribution of the chromosome 15 is not functioning right. It's not functional. This happens. Prader-Willi occurs 1 in 12,000 to 15,000 births. And there's no difference in sexes as far as is it more prevalent in boys versus girls, and there's no difference in races. It affects all races in both girls and boys. The major characteristics we see with Prader-Willi syndrome is the child has hypotonia, so they're low tone. They're hypogonadism, so there's an issue with some of their hormones. They're not producing the hormones that they should. And there's hyperphagia. So there is excessive eating, which I think is really interesting with Prader-Willi. So hyperphagia is excessive eating. There's going to be cognitive impairment or intellectual disabilities, and there's some difficult behaviors as well. A major medical concern for individuals with Prader-Willi is morbid obesity because of that hyperphagia.